and very happy to have Ryan join us. Ryan is a professor of medicine, hematologist, critical care physician, and clinician scientist at the University of Manitoba and Cancer Care Manitoba. His research focuses on the hematologic aspects of critical illness, where he leads several national and international randomized trials in the fields of sepsis immunomodulation, anticoagulation, and blood conservation. In the course of the COVID-19 pandemic, Dr. Zarychanski and team developed novel clinical trial methods to speed knowledge generation and facilitate global collaboration. And these novel adaptive platform trials identified several effective therapies for hospitalized patients that have been adopted in both Canada and globally. In Canada, Dr. Zarychanski co-chairs the Accelerating Clinical Trials Consortia Clinical Trial Unit Committee, and in Manitoba, he directs academic contract research organization that designs and supports randomized trials for investigative teams for several provinces. So he comes very well qualified to speak on this month's topic, which is the, let me see if I've got the correct title that you gave us here, Ryan. It was the promise and perils of adaptive platform trials, which I think is useful information for us to review. And with that, Ryan, I will give you the floor to present.
Sure. Well, thanks, Jacob. That was really nice. Do you think I should start? Should I wait? I see there's like 10 people online. I'm not sure how many people you're expecting. Happy to take your direction, obviously.
We usually have between 10 and 20. So I think, it may be a little quieter now because we're closer to the holidays, but yeah, go ahead and start. There may have people who join late. But you are muted.
Oh, perfect.
Yeah.
Excellent. That was a test run, really test run.
Okay.
Okay. I'm Ryan. I'm going to talk about platform trials today. And this is something that I do like every day with the trials that I am involved in or lead. I think that there's a huge advantage in knowing about them and interacting with them, participating with them in them and leading them. I think that there's huge opportunities for the Canadian Transfusion group around around novel trial designs in general. I think the trials that we've inherited aren't the trials that we should likely be performing on a day-to-day basis anymore. And that's just medicine, right? Like we're not treating heart failure the same way either, and many other conditions. That said, let's talk about platform trials a little bit. Okay, so I'm going to share my screen here. Just a second. If I can't see if anyone has a question during the presentation, but if you do, maybe Jacob or anyone could interrupt. Like, I'm happy to have a discussion as things evolve. You don't have to wait to the end, kind of thing. But I won't likely be aware of it.
For sure. Yeah, I think people have muted themselves, but they are not enforced to mute. And if they want to come off
Yeah,
mute and ask a
yeah.
question, you are allowed and encouraged.
Can everyone see that?
Yes, that's showing perfectly.
Okay. Okay, so disclosures related to really federal and other grant funding for trials that I participate in there as a chair or a co-PI. And many of them are adaptive platform trials like ATTAC-CAP and MyeloCan. That's one of my mentees, Brett Houston, who's leading MyeloCan. It's an adaptive platform trial in AML and elderly MDS. No, elderly AML and MDS that is launching this year. Remap Cap, you'll hear about it in this presentation. Brain App, which is one that I'm developing with my colleague in Quebec, Alexis Turgeon. Practical is out of Toronto, and Ewan Gallagher. These are all adaptive platform trials. We're going to talk about traditional trial designs. What is a platform trial? Opportunities and challenges. Okay, I won't belabor this, but it's just important to recognize. Like RCTs are they're needed, right? We need to prove or disprove therapies or devices with rigorous evidence, that takes an RCT. It really does, for the most part. The problem is there's a lot of challenges in the RCT that has been handed to us from the 1950s. The original RCT, the David Sackett RCT and others, is that they're slow, like, and they're at arm's length from critical care. So we have like, like research nurses and clinical nurses, and and approval process for research and for clinical stuff, and even data collection that's separate, etc. They take a long time to conduct because there's some planning, piloting, funding, etc. And it could be like 10 years, and it doesn't keep up with, or like with discovery. Like we're discovering new genes and stuff all the time, and mechanisms, and by the time we studied one drug, we're on to the next targetable or druggable, target, that kind of thing. And there's this false dichotomy, as I alluded to. It's like studying or doing, and this came up, like, it comes up all the time in their hospital system. I know it does. Where like you have to consent people to approach them for research, but not for care. But like they're the same thing. Like good clinical care includes good research. Just like, and we saw this in the pandemic with that push and pull about like just do something versus like let's know about this more, and we often have this false dichotomy. We're very limited by the frequentist paradigm we've all inherited. Okay, like our mentors are brilliant people, and we should be grateful for them. And I'm grateful for my mentors. But it took us so far, and there's a whole world beyond the standard P value and the frequentist challenges that come up. And I'm going to talk about this a little bit more. We dichotomize everything as significant or not significant, and we lose like most of the information of a clinical trial, and it's really holding us back. 95% of trials that we plan, fund, conduct are underpowered to detect meaningful clinical differences. 95%. And imagine if this was a drug, right? Like imagine, and we knew this, and imagine if you had like some urgent condition, which all are in priority condition, which are all priority conditions. Why would we be studying it? And we knew that if we applied this drug, you had a 95% chance of not telling you the answer you want. Like, would you keep giving the drug? Of course you wouldn't. But we keep applying the same trial design over and over again when we know that it's failing us. This failed us before the pandemic. 95% of trials were underpowered. 95% of trials within the pandemic were underpowered, and they continue to be. And we do this because like in a frequentist framework of trial design, we have to like set the parameters often for the trial. We have to set like what is the control event rate, which we always overestimate, by the way. Because it's part of grant writing and stuff. Like, oh, like this has a 50% mortality, but it's really only like 32%. So we always like overestimate the control event rate. We always overestimate the effect size for the most part, and we don't pay a lot of attention to the standard deviation, but we probably will underestimate that as well. And we don't do a lot of pretrial simulation with frequentist trials. We kind of take the best guess that we have, and we go through the whole trial with these guesses, regardless of what the trial shows. Like most of the trials are insensitive to the information that accumulates that could have told us that our fixed parameters are wrong, but we don't pay attention to it. So we end up with 95% of trials that are empowered. And I really want you to like internalize that and challenge me if you want. It's a fact. It's hard maybe to, but it's like, wow, it's just shocking to me that we continue to perpetuate the same errors, knowing that the system we have is inherently flawed. Actually, it doesn't mean we have to abandon any of the trial. And I'm not the largest fan of frequentist trials that I was when I started, but there's still adaptations and still information to be gained as frequentist trials can evolve, but we don't often pay attention to that. And so I would submit to you that maybe this is the more provocative statement, that I would submit to you that our practice of designing and conducting randomized trials on average is likely unethical, because we know, maybe you didn't know this before the talk, but we as the larger, we know that these trials are failing us over and over again, but we are doing them, and we, the taxpayers, are funding them. We're taking the taxpayer money knowing that they're poorly designed to answer important questions. And these aren't like abstract things. I could have, and I didn't have a lot of time beforehand to put these examples in, but I should have, and I just threw in one. But here's one that was just from like published a few weeks ago. This is Shane English's study of a transfusion example, liberal versus transfusion strategy for an aneurysmal subarachnoid hemorrhage. And so, what's the result of this trial? This is like comparing, like I think it was 90 versus 70 for subarachnoid hemorrhage, critically ill patients. And the result here is like an unfavorable outcome occurred in 33% of people with liberal, that's like more blood, versus 37, which is less blood. So it looks like, you'd want to maybe give them a little bit more blood in this population, a higher transfusion target. But because this was the fixed parameter trial, like the control event rate, the assumed effect rate, and the variability, we come up with an answer at the end of the day that's yes or no. Yes or no. All this information. And what is the probability like that this intervention works? And why it's probably higher than yes or no. It is higher. Of course it's higher. And wouldn't we want to continue this trial till we just had the right answer? Yes, of course we would, but we don't. This example also came up with Alexis Turgeon's trial in traumatic brain injury. That's a transfusion trial again in TBI, which again showed a clinically relevant benefit with the liberal transfusion strategy. But in the context of the trial design, it's dichotomized into not significant. And he likely, I haven't talked to him personally about that, but he likely wishes that he used more adaptations in the trial design as it progressed. Well, these are just examples, like from the last few months, and I think that we should give more thought about incorporating adaptations in either framework, a Bayesian or a frequentist framework. In addition to that, trials are insensitive to heterogeneous treatment effects. And so we know that 75% of the effect of a clinical trial, if it's positive or negative, particularly if it's positive, is accrued by a small proportion of the patients. This has been known for like 20 or 30 years by John Ioannidis and colleagues, where most of the benefit, if it's positive, is accrued by a small amount of people. And so that means if a trial has a beneficial effect, some will benefit, most won't, and perhaps some will be harmed. And we apply that average treatment effect to everyone at the end of the trial, but we know, whether we admit it ourselves or we recognize it inside of ourselves, but it's a fact that the majority of people won't have the outcome that we saw as the average treatment effect within a trial. Likewise, in a negative trial, not everyone would have not benefited, and some would have. And how do we get at that? How do we turn that average treatment effect into an individual treatment effect? Right now, we don't do that in clinical trials. And we've known this for a long time. This is an example from 1995, one of the original, was it called the ECAS trial? When carotid surgery for carotid endarterectomy, and they looked at your stroke risk, I think with ultrasound at this time. They looked at your predicted stroke risk and prior to surgery. And if your stroke risk was low, there wasn't a lot of benefit. In fact, the surgeons made you worse. There was no benefit. In fact, you were harmed by the procedure. But if your risk of stroke was very high, then your absolute risk reduction with the surgery was greater. And so although there was an average treatment effect that was positive for carotid endarterectomy, you wouldn't want this procedure done to you if you had a low predicted risk. This is an example of heterogeneous treatment effects that almost applies to kind of every trial, to be honest, but we ignore these. And we probably need to do better. They're slow, as I said, they're expensive. And we often build up a whole set of infrastructure. Like we build a whole arena just to play a hockey game. We build up a whole bunch of infrastructure just to conduct one trial, and then we take it down again and build it up for the next one, instead of having an arena already made and just is selling tickets or opening a gate and come into this gate, watch the game, come into the next game, or like an airport sort of setting. We don't build an airport every time we want to take a flight. We have infrastructure set up, and we just utilize infrastructure to efficiently conduct a new trial or go to a new destination. Trials often evaluate one intervention at a time, and that really ignores the complexities of care. And then the consequences they're real, and I think that they're unfortunate. Is that like less than 5% of patients are enrolled into clinical trials. The majority of the trials fail to answer their intended question, as I mentioned. The research remains squarely separated from clinical care, and the progress is painfully slow. We got to do better. We have to do better, and I think that we can do better. And I'm going to focus on the Bayesian adaptive platform trials, but it's not to the exclusion of tweaking the other trial designs out there, like building in adaptations to frequentist designs as well. So, what is an adaptive trial? So as opposed to the traditional fixed trial design where you design it and all those parameters that I talked about, you set, you conduct it, and you analyze it. Adaptive trial designs are sensitive to information that accumulates as the trial progresses. And as the information accumulates, you might incorporate these data into adaptations that then allow the trial to continue in some different way, and analyze it at the end when you reach some conclusion. They can resemble and lean into clinical care a little bit more. The trial design, the adaptations are designed to maximize statistical efficiency, achieve better outcomes, that has come to a conclusion that's useful or not, and also resemble clinical care a little bit more. And let me come back to that. Here's an example. And so some people are uncomfortable with randomization. They're okay when things like, I don't know, like when the pressure's not high or something like that, or when there's amazing amounts of equipoise. But often, like in a setting of critical care, it's like, this person's too sick for me to randomize because I think I know what to do, which is like, oh my God, I'm so done with that as a critical care doctor too, because we've mostly guessed wrong in critical care. And almost all of the trials and gains in critical care we made over the last 20 years are simply deconstructing the practices that we put into place because we thought we knew better. That's most of the gains in critical care. And that's just the reality. That's the truth. Under oxygenating, under sedating, like currently, like that is, responsive fluid resuscitation, mobilization, all this stuff, like transfusing appropriately, undoing all the things that we thought were beneficial. And so people can be reluctant to randomize sometimes. And here's an example of an adaptation called response adaptive randomization that can make clinical research feel like a little bit more like clinical care, like a doctor who wants to care for their patient and give them the best therapy. So what is responsive randomization if you're not sure? Responsive randomization is a technique whereby you might be studying several drugs at once. They're all randomized to patients within equal proportions, but as data accumulates in a blinded way, the randomization allocation can change to favor the drug that's most beneficial to patients. And so as the trial progresses, drug 2 seems to be working a little bit more. We don't know that at first, but the allocation proportion changes. So a few more people get randomized to it than drug 1. As the trial progresses further, maybe drug 2 gets even more people randomized, and then it reaches a superiority threshold or a trigger. It's pulled out, maybe it becomes a standard of care now, maybe another trial is added. And so it helps clinicians feel a bit more comfortable with randomization, say, listen, I won't have as much control anymore, but at least I can be sure that the patients are receiving the drugs that seem to be working, and which I think is more responsible in guessing. But there are lots of other types of adaptations, like sample size reassessment as things go, because we might underestimate our power, and this is a good way to recoup that. Group sequential stopping, which I'm going to come back to, but it's a really powerful technique to identify groups within trials that have differential treatment effects. We've experimented the last few years with seamless phase 1, phase 2, phase 3 designs, where a trial might progress through all those phases in a seamless fashion. Enrichment designs, where we might evaluate the criteria for being in the trial, or the enrollment criteria, the inclusion or exclusion, as the trial progresses, enriching the population based on risk factors, risks of success, that is, or risks of failure, etc. And so adaptations can be used in a frequentist framework, for sure. They can be used in a Bayesian framework. Those are adaptations. So what's a platform trial? So a platform trial is a little bit different. Platform trials uses a master protocol as the foundation to study other interventions, and it's often multiple interventions at one time, or interventions over time. So adaptations are simply changing the trial as it progresses. It can be done with any trial. Platform trials use a master protocol to guide the operations of a trial. In the context of a master protocol, you could have several interventions, perhaps organized under domains. Like those are sort of themes of interventions. It could just be lots of interventions under one domain too. But here's an example. So imagine you have a master protocol saying you're studying transfusion. Let's say in, like, I don't know, in bleeding from non-cardiac surgery. And you have different interventions studying at the same time, or being studied at the same time. You have frequent interim analyses at some portion of the interim analysis. This intervention meets a pre-specified trigger for futility, so it's withdrawn. You continue with the other two therapies. That's at another point. Maybe intervention 4 is brought in. Maybe at some point in the intervention 2 now reaches a specified trigger for efficacy, so it becomes the new standard of care for which intervention 4 is compared against. Maybe 5 and 6 are added. And so what it does, it's a structure to allow an ecosystem of research under a certain topic or theme of research, so that there's constant knowledge generation and a constant operational infrastructure of research that allows one to continually optimize care within a population or within a question. This structure was we sort of presented in a paper here if you're interested. And so the traditional platform, the traditional trial design has trial A, followed by trial B, followed by C, that are discontinuous. They're generally not overlapping. And I said, for all the limitations, versus the platform trial where multiple interventions can be studied at once. It can lean into clinical care. Even the sequential studying of different interventions is, I think, a benefit because it mimics the complexities of a real clinical care environment. And it really builds an efficiency to the process, coming to answers for priority questions in a really efficient manner. I've hinted a little bit at Bayesian statistical frameworks. It's not meant to be dichotomous or polarizing here, by the way. That's not my intention. Bayesian statistical frameworks are not required to operate adaptive platform trials, but I think they sure make it easier. And to be honest, I think that they have strength because it mimics the way we think in clinical care. Like when we take a trial, any trial that you're thinking of right now, a frequentist trial that's positive, and it rejected the null hypothesis based on long run statistics, that is the p-value and confidence limits, and the way we disprove hypotheses and framework. We don't go back to the patient and say, hey, like, we're going to give you this drug because in 19 out of 20 or 95% of the time, if we repeated this in a theoretical population, we'd achieve a point estimate this or greater, which just proves the null hypothesis. And the patient goes like, what? We don't even say that, by the way. Instead we go, hey, if you give it this drug, there's a 30% chance you're going to do better, which is actually a Bayesian expression So we Bayesianize things anyway. Today, I didn't wear my hat outside because I knew the probability that it would be less than -5 or higher was super high. It's like a -3 right now in Winnipeg. And we make decisions based on probability. And then all the time, we diagnose patients based on probability, and we Bayesianize the treatment effects of frequentist trials that test the null hypothesis or disprove the null hypothesis. We change that into a Bayesian expression already. This is the way we think, and please, I hope you recognize that. Bayesian statistics sound like it's foreign because we don't learn it in medical school, but again, it's the way we think. We have a belief or a prior probability that something works or not. If we don't, we just call it neutral. That's just like the way trials are done anyway. So maybe we don't have any belief. And then we have an effect estimate in the trial, like that's the likelihood, that's what did the intervention do? Just like, and think of this diagnostically, like you may have chest pain or swollen leg, and what's our pretest probability of you having a DVT? Apply the Weld score. That's the prior probability. Then I do a test or I do a trial. In the case of intervention, it gives us a likelihood ratio, and then that prior with the likelihood ratio now gives us a posterior probability. Or a post-test probability if it's a diagnostic test that some intervention is beneficial or some disease exists. This is the way we do medicine. This is the way we think. It's naturally sequential. That is Bayesian statistics, so we can update our beliefs, update our notions of success or not or non-success as trial information accumulates, and it performs really well in the setting of unknowns. And so again, in the fixed trial designs, we have to, as I said, set the control event rate and the effect estimate, and we can do that. We still need to set parameters in a Bayesian trial for sure, but with pretrial simulation, we can give a range of possible estimates, and we can continue the trial until a trigger is reached, versus setting the effect estimates, having a fixed sense of what the power will be when we reach a certain amount and stopping it then regardless of what happens. This is an example of how Bayesian statistics are used in medicine all the time, about like the chest pain example and the pretest probability of you having coronary arteries based on your presentation. We put you on a treadmill and it may change this or not, bumps it up to a little bit more, 60%. Okay, is that enough for me to do an angiogram or angioplasty? I'm not sure. Maybe we should do MIBI, nuclear test that will now present with a likelihood ratio. So my pretest probability has been modified. Likelihood ratio is now really high based on the test we've done. Now my post-test probability is really high. Now I think that's enough to send you to an angiogram. Just want to let you know, this is how we already do things. But we have this structure in place for clinical trials, which is very foreign to us, which is so foreign to us that we actually change the results of it to a Bayesian expression when we use the information or explain it to patients. This is a model that we use to conduct the analysis for a platform trial called REMAP-CAP that allows us to not only calculate the effect size based on Bayes' theorem, but allows us to introduce other covariates like site and time into the expression. So with updated models and interim analysis, we can evaluate the effect of an intervention over and over again until we reach a conclusion. In this case, our conclusion, again, it's a priori, was based on a probability, a posterior probability, that the odds ratio was greater than 1. And we wanted a 99% probability that the odds ratio was greater than 1. And we set futility as a posterior probability that an odds ratio of like 1.2, so some larger effect, was very small. And we continued these trials off until we saw a trigger. And wouldn't that be great if we could always have an answer? Wouldn't that be great if we could demonstrate that a trial could do this at multiple interventions at the same time. And this was how REMAP-CAP, this was a trial that studied therapies in COVID, but it's studying therapies in non-COVID pneumonia as well. But this is an expression of the REMAP-CAP trial where we ran the trial over time. You can see from March 20 to March 22, multiple interventions were studied at once, whether they're antibiotics, immunomodulation, convalescent plasma, therapeutic anticoagulation, which is a domain that I led, vitamin C's here, simvastatin. And what's more impressive, though, what's really more impressive is that these are the trials, these are the interventions that were studied simultaneously or sequentially over time. And these are the trials that were also stopped when they reached a conclusion. And versus when we thought they might reach a conclusion for which 95% of trials are underpowered. So all of these trials came with meaningful conclusions at the end of the day for all the effort we put into it. And it was because of the trial design, not because they had adaptations built in, but that helped a lot, is because we stopped when we had the answer versus we stopped when we predicted we would based on fixed parameters. This trial ran in 14 countries or so, in hundreds of sites, and the conclusions were impactful, not because it was a pandemic, I want to say that again, but it's because they're published in the New England or in Lancet or in JAMA over and over again, and these are some of them, because they came to conclusions all the time instead of a trial that was impervious to the trial data that accumulated. Okay, beyond the operational efficiencies and ability to come up with answers, our platform, what other opportunities do platform trials have? But one of them, I think, is the notion of exploring heterogeneous treatment effects. And I do want to just touch on this a little bit, is that I recall that that clinical trials right now, when they're finished and reported in any journal, they say the average treatment effect in that trial, but almost no one, probably no one, undergoes or experiences that average treatment effect. Instead, based on a patient's risk profile, either their biologic risk or risk of benefiting or not benefiting, they experience a different outcome. And we apply that average treatment effect to the patient, though, knowing that only 25% of patients even contribute to the outcome, and that only a few of those will be benefited and some will be harmed. There are different ways to categorize heterogeneous treatment effects. Some are effect-based, that is, like based on like different, phenotypes or mutations or some trait that affects the causal pathway of the treatment. Some patients will benefit or not. This example came from phenotypes in ARDS. But then some patients will benefit based on their risk, like severity of illness or something like that. We took advantage of that, and so this is like introducing the concept of heterogeneous treatment effects, appreciating that they exist in trials and that we generally ignore them, and that they can be broken up into like treatment effect by like mechanisms or treatment effect by risk, perhaps, to a patient. How do we incorporate that? How do we incorporate that into clinical trials? We don't, first of all. We should, second of all. Here's an example of how we did this when we studied therapeutic anticoagulation in COVID. I'm going to say this is an example. It's not like perfect. We're making up methods. Like we're developing more sophisticated methods now. But here's what we did in the context of the pandemic: is that when the pandemic started, we knew that people were getting sick quickly. Their death rate was high. A lot of inflammation. Many people had thrombosis, but we actually never cared about the thrombosis. We cared about the inflammation and the organ dysfunction. And so we wanted to study therapeutic anticoagulation as an anti-inflammatory agent that may reduce microthrombosis also. Some people were high risk of disease, some people were at low risk. We wanted to do this quickly, so we actually designed a new type of trial design that we called the multi-platform trial, where we took 3 separate platforms. One of them was ATTACK, one of them was Active4. ATTACK was in Canada, United States, and Brazil for the most part. Active was in the United States for the most part, and REMAP-CAP was distributed around the world, but mostly in Europe and Australia as the enrollers for the most part. And what we did is we harmonized all the treatment in the treatment stuff, the inclusion criteria for the most part, and we made them to be like 96% homologous in their inclusion in their PICO questions. Oh, sorry. And then we conducted the trial, and we integrated all the data into one statistical model. So they were federated at a clinical trial data level into one statistical model at the end. So we treated it as one trial, not like a meta-analysis. So we called it the multi-platform trial that we're developing a paper to explain more carefully and more thoughtfully in the next few months, hopefully. To take advantage, and think about this in the context of transfusion, like when you might do a trial in some population and you are gonna come up with an average treatment effect, but really of risk groups of interest. And so we had risk groups of interest in ours. We had moderately sick people, those are people on the ward, and we had severely sick people. And we broke up the moderately sick people, those are people in the ICU, by the way, severe. Moderately ill, we broke them into like high D-dimer, low D-dimer, or unknown D-dimer. And we employed a statistical technique called dynamic borrowing, whereby these groups could share information. So low could share with high, severe could even share with moderate if they were the same. So if the trial progressed and all the effect estimates are the same, this would be one large trial at the end of the day. If they were different, then they would separate and say, listen, these can't be included in the same point estimate. They're going to be separate. Then within moderate, if they were all the same, then all these D-dimer groups would report together. If they were separate, then they'd be reported separately. So it's a way to build an HTE, or an heterogeneous treatment effect analysis, prospectively as a trial unfolds. And what did we find? We found out that in our pre-specified interim analysis that are frequent but blinded to us, we reached a futility conclusion for this severe group at some point. So we stopped enrollment. And we reported it. And with a lot of confidence, we had like 99.9% probability that what we're doing was not good for you. So we stopped it. In fact, we had a high chance that it's also harmful. So that was also not a good situation to be. We then continued in moderate. And so the moderate groups continued. And then we applied response adaptive randomization. So I didn't know which group was benefiting, but there was a change in the allocation proportion based on the groups that were benefiting. The trial was continued, and then it was stopped when we reached a conclusion for superiority this time. And then we reported them as 2 separate trials, one in severe, one in not severe. And in the non-critically ill patients, there was a high probability, 99% probability, that therapeutic heparin was beneficial, and then it was the reverse in the critically ill patient. Why I bring this up is it's you can put this to your own example, saying, listen, like we think that we assume that a condition works, or sorry, that a treatment works. Usually doesn't, but that's okay. If it does work, we assume it works in everyone. It rarely ever does that. And are there ways that we can figure out or plan for heterogeneous treatment effects within clinical trials? This is an example. It's not perfect, and I can talk about that more. We subsequently tried to develop different methods of detecting heterogeneous treatment effects in trials, and I talked about risk-based, that's the middle one here, and effect-based, that's like based on severity of illness as a risk or different covariates, or effect-based, like what predicts your response to a treatment, what the risk of you responding kind of thing. versus conventional subgroups. And we published a paper on this that might be interesting to some people in JAMA. But again, like it takes this concept a little bit further, but we have a long ways to go. And so we analyzed our multi-platform trial using conventional subgroups, which is like one-off subgroups, which are always hypothesis generating, versus a risk-based model, which we could detect an effect based on monotonic risk. So the lowest group people benefit and the highest group people didn't. And if we had built that in prospectively, wouldn't that have been really amazing and powerful? And likewise, we found effects that were different based on predictors. And in this case, the predictors were centered around BMI and severity of illness. Okay, switching gears a little bit, we studied anticoagulation. And again, we studied it using an adaptive platform method that allowed us to do all of this in the context of other things being studied at the same time. So imagine a transfusion question or something that would be relevant to the transfusion trials group, where you have a program of research in like cardiac surgery, and you're studying fibrinogen here, and maybe PEG here, and cell salvage here, or something like this. So all things at once under an ecosystem research, instead of building up the airport or creating infrastructure for a trial each and every time. In the inter-pandemic phase, we're now advancing and sort of refining the multi-platform methods that we created in COVID-19. And we've launched another multi-platform initiative that we call GUARD, the Global Unified Adaptive Research in Infectious Diseases, where we're collaborating with REMAP-CAP now to study therapies and community-acquired pneumonia, which is the most common cause of hospital admission in the world, other than child delivery. And I'm interested in immunomodulation, anticoagulation as a hematologist, but other things are being studied as well. So steroids, antibiotics, etc., all within a platform structure. We are actually, I'm going to skip that just about the rationale for it. But this is what it looks like the architecture-wise, where we have hospitalized patients with suspected or proven infection. We have just launched this syndrome of the adaptive platform trial now, where we have a registry-only component and anticoagulation, steroids, antibiotics. And then other syndromes can be populated, like PJP pneumonia or some other non-pneumonia related infection, as the trial progresses and other leaders emerge who want to participate and use the platform infrastructure. We're again focused on the ward right now, but we actually just got funding for a post-discharge platform that Patrick Lawler, a really close friend and collaborator in GUARD, will be leading. So after patients get discharged from the hospital, there's a randomization point for them to study interventions to reduce sequelae, thrombosis is on our mind, inflammation, and quality of life after sepsis. We are collaborating now to form a larger platform initiative across the spectrum of care, with pre-hospital and the ICU groups, to form sort of a very integrated to form integrated platform infrastructure that will help Canada prepare for future pandemics. Those are, again, some of the interventions in GUARD. Again, like as a hematologist, I'm more interested in anticoagulation and immunomodulation. We have 60 activated sites now, and we're expanding to 100, hopefully by the end of 2025. Australia, Saudi Arabia, Colombia, Mexico. We have 350-ish enrolled right now. This is an outdated slide. And embedded into the trial is a really sophisticated a priori method to detect HD or heterogeneous treatment effects as the trial progresses, using a constellation of biomarkers, clinical risk scores, and pneumonia etiology. And then we do this at different stages of the trial as the trial progresses. So there are adaptive interim analyses, and there are a priori plans to conduct or to enrich the population or de-enrich based on people who are benefiting or not benefiting. So change the inclusion criteria. and then have group sequential stopping rules. So based on different groups that are identified, people will either continue or stop or be merged with ones that are the same, similar to how I introduced in attack cap. So again, these are like trial methods that could just kind of tweak their RCT, that the parallel group RCT with fixed parameters that we've conducted over time. That I'm not poo-pooing it. I don't want to create that dichotomy within us, but I want to say, like, there's other methods that we should be embracing and exploring together and really be excited about, um, um, because they can be beneficial for our patients to come up with efficient answers in a time frame that can hopefully keep pace with some of our discovery at the same time. And at the end of the day, the idea is to lean in to our research can lean into clinical care a little bit, where we're not so separated anymore, where we're the data that we're collecting for clinical care then can be used for clinical research, that the information that we collect them in trials can be fed immediately back into clinical care. Our personnel could have multiple roles, and at the end of the day, our system's more efficient. And I think this is part of the learning health system. This is a reflection. This is an expression of what we talk about in abstract terms, learning health system. But this can be that, where clinical research is embedded into clinical care with enduring trial infrastructure that is integrated into how we manage patients. So we're learning while we're doing at the same time. I've talked about the benefits of this, but there are challenges too. There's some specialized methods, some complex statistics. Those aren't challenges. I'm serious. I put them up there as but computers do this, and experts exist, and methods exist too. And so don't consider this a barrier, because it shouldn't be. You do need some specialized people to understand what platform methods are, and the challenges of sometimes contracting and consent and payment. Our funding mechanisms in Canada don't really scale well for platform trials that don't have fixed endpoints. And so that's a huge challenge. And oh my God, I hope Paul LeBert, as the president of CHR, will talk to us and interact with the community to come up with solutions around that, because we really need to be funding these platforms more thoughtfully and enduringly, etc. Okay, so in conclusion, adaptive platform trials, they do offer operational and statistical efficiencies, and they may address some limitations of traditional RCTs. I think they can reduce the clinical divide between clinical care and research. They have some really exciting opportunities to detect and respond to heterogeneous treatment effects, getting further at the individual treatment effect versus the average treatment effect, which is the holy grail of all clinical research, of course. And it's an opportunity to create collaborative ecosystems of research to advance knowledge generation, improve health outcomes as we look after patients. Thank you very much for the opportunity to present the group. Really excited about the methods, really open to those who want to explore these. Our group has some experience doing this. So if you want to help design a platform trial, help operationalize that, come talk. And we do this for many trials like Attack Cap, Guard, Defend Cap, Clear Horizons, MiloCan. We do the data coordination for platform trials for others in other provinces as well. We're a very collaborative group in Manitoba. We work very closely with those in Ontario and other universities as well. So don't be shy. It's a very welcoming group.
Okay, Ryan, thank you so much for that. It's a complex subject, and I think you presented it very clearly, and you made a very compelling case. You kind of put out there at the very beginning that you thought it was almost unethical to continue performing sort of traditional randomized controlled trials. So I was listening all the way along for counter arguments I could think of to that, because I think we still are very attached to these old ways, and this is still how we do our journal clubs and that kind of thing. but you've made a very compelling case, just for the efficiency of these more sort of modern adaptive platform trials and getting answers in the seamless trial designs, that we see coming more and more from industry. Um, and obviously the importance of embedding, this whole infrastructure in regular clinical care. I guess my question for you is that you didn't spend too many slides on the perils, and they were mostly, just sort of what I took from that is that this is just hard and it takes a lot of resources to do this, to kind of get it up and running. Is there not another peril though, having to do with the data being generated itself? Are we losing something by moving away from traditional frequentist RCTs in terms of the precision of the answers that we are getting, in terms of the physiologic understanding that we gather from those traditional trials? I mean, I think, when you have these adaptive protocols where you sort of try something, pick it up, didn't work, drop it, move on, are you losing something along the way? Are you, or is there information that we would otherwise have got had we done a more traditional RCT of each one of those individual interventions?
No, thanks for bringing that up. For sure. And so the answer is no, we're not losing anything, and then we're gaining everything along the way. So we're not losing anything because what you described has to do more with, like, I don't know, I think a pragmatic trial or something that could be inherent to any trial design if it's not physiologically not precise, or that's just I think that's more of a factor of what you're studying and what you're collecting. And so you can do pragmatic trials, and some of these were, but some of them are like practical, like the platform trial that Ewan Gallagher leads with Eddie Pham out of UHN. Those are, many of the interventions are very unpractical. Like, even just called practical, like they're physiological based, because it's Ewan, right? And he's like a PhD in physiology, and there's like high fidelity. They'll only work in a few sites, but the data they get is going to be like incredibly useful to that question. And so it depends on what you collect. I think that, and I want to challenge, and again, I'm not I'm not like here to like sell or like anything. I just want to provide a different perspective. And I may be favoring the perspective, not because I want to be biased, but because I think people are unfamiliar with it. And so I want to give them some experience around it. But the p-value though was the worst loss of information, right? Like, look at Shane's. I could have put up Alexi's on there, look up his emotion trial. But all that data, 742 patients coming down to significant or non-significant, what a travesty. What a travesty. And so instead of what's the probability of this benefit? Like, so we just came up with we're just submitting a trial on intermediate dose heparin. Like, that whole thing that came up with COVID with intermediate dose, like what was that? I don't even know, just got invented. But the UK really adopted that, and they had intermediate versus not. And if we did a frequentist p-value thing, it would be like not significant, but there's an 83% probability that this drug, intermediate at that dose, worked better than standard prophylaxis. If you didn't like therapeutic, that is, if you didn't like it. And so it's like, okay, and there's no bleeding whatsoever, no bleeding. And so it's, again, like on a p-value perspective, we would say, no difference. But at a patient perspective, imagine this, like, well, look at, there's an 83% probability that this drug that is super cheap, that has no harm in the trial of thousands of patients, no harm, that's widely available, could reduce your chance of dying by this amount. If you're the doctor or the patient, wouldn't you want to hear about that versus like, not significant? And so I think that there's actually more value created with the data that we're collecting, regardless of the type of data. And then getting to your original point was like the fidelity of the data can be guided further. All of these trials, I might add, for the most part, that I presented, that I have a leadership role in, we all have an embedded translational component too that I somehow failed to mention today. But like a TACAP, DefenCap, Plexus, they have like a translational lead that we're developing, like knowledge based on biomarkers and tests, new tests, and DNA methylation and stuff that could help further get at that individual treatment effect by taking the point estimate, adjusting it for the translational knowledge that's generated, and look at the models that I present too that have time, site, age. What kind of frequentist trial has that currently? They all can, by the way, you can adjust your outcome for multiple things, but it's just not common. And so let's stop doing what we've continually done and bring more value into the trials, regardless of the framework.
Okay, thank you. Anyone else in the audience have any questions or comments to make?
Hello, Johnny Mac.
Hi, Ryan.
Good
Thanks
to
a lot
your
for a great
name.
talk. I had a question for you,
Sure.
and then Jacob, there's a couple questions in the chat.
See those there? Yes.
Might be worth a question for you, Ryan. I guess just about heterogeneous treatment effects. I guess as we get more experience with that, do you think we can become less and less, or can we become less restrictive with our eligibility criteria?
Can we become less restrictive?
Can
Oh yeah,
you
can we
like
can we take a
with
shotgun to it and then narrow it as the trial progresses? Is that what you mean?
yeah.
Yeah, I think so. That's what we're doing with the TAC cap. Like we're like, okay, we're including everyone with pneumonia, but like, what are the odds that everyone with pneumonia will benefit from therapeutic anticoagulation? There's zero. There's zero. All right. But how do I guess who benefits? Like I look at what we did in heparin. I thought it was the critical care people that would benefit. It was totally wrong. But thank gosh we incorporated this because the opposite hypothesis was true, and then shown in multiple trials other than our own. So it was like the hypothesis had durability because it was proven in five other times. And so we decided to start with a broad population and then building these methods then so the data can tell us who's benefiting versus us guessing, because I've come from critical care. We're the crappiest guessers out there, despite the egos that accompany the group. And so we wanted the data to guide how we change the enrollment criteria versus our preconceived notions of who may benefit.
Right. So is that, I guess, where do you draw that line in terms of, I guess, losing? Because I imagine that if you were overly broad, you're going to be losing a lot of time and patient enrollment at the very beginning of your trial.
Yeah,
So
for
you have to
sure. I
sort
mean,
of draw a
there's
line
these,
somewhere. Like where do you
yeah.
view that line as being appropriate, like without
Well,
entering
I think,
in?
yeah, I mean, I think that depends on the patient population, what you're studying, and the data you have available to us. Like, so we knew that people with pneumonia have a certain risk of an outcome of a certain percentage if they're on oxygen versus not on oxygen. So we said, okay, listen, everyone must be on oxygen because other than that, the outcomes are too rare. So that's an example of where it wasn't just people with pneumonia, it was hospitalized people. They had to be on oxygen. And now we have a population that we think has sufficient outcomes to make a trial feasible. Within that group, now we're going to come up with higher risk groups based on their covariates or risk in general of benefiting or not based on a few factors that we guessed at. If I could do it again with unlimited money, then I would use like sort of causal forest methods so that the data was totally pick the variables of interest. But we felt that was infeasible, so we guessed on the variables that we're interested in based on data that was available to us in the literature. So there's still trade-offs, and we didn't get this perfect, but it's a start, and science is iterative, and I'm okay with that. Yeah.
Okay. We're
Thanks.
just a little bit past time, but I'm wondering if I could just maybe quickly get you to address the questions in the chat. I'll read them both
Oh
out.
yeah, sorry.
They're sort of speaking to the same issue. First comment, I think this is from Christine. Fantastic talk and admiration for this profoundly progressive work. Can you please speak to blinding and bias management in this design, i.e. awareness of who is on what with adaptive knowledge of resources along the way versus blinding, data safety of monitoring boards and classic RCTs. So one question about blinding and
Okay.
bias. The other question, I
So
think,
can I answer that very quickly?
yeah.
So blinding of interventions, that's not to deal with this. Like that's like, that depends on your intervention, your outcome, and that this trial design doesn't affect that. So some of our interventions are blinded and some aren't based on standard things that you do taught and had experience with. But blinding for adaptations, you must be blinded for sure. So all of this, it looks like we're making it up as we go along, but we're not. It's all a priori. And the investigators are always blinded, and we have a blinded statistical team and we have an unblinded statistical team that that just affects the trial design that we came up with. So they do it, and I don't hear about it, kind of thing. And the data safety monitoring board is blinded unless they think it's a safety concern. Otherwise, that's standard, not controversial. Still important, and definitely got to consider that.
I think it's more the probably the bias, and maybe not, you know, the investigator bias, but maybe the selection bias, that sort of thing, which I think the second question is speaking to, which is, you know, this question of regression to the mean, that you expect. And if you are changing randomization versus outcomes, are you not, you know, creating a bias in terms of, you know, favoring, you know, one trial maybe or one intervention prematurely over another. I mean, there's a reason that we have these traditional, random allocation strategies. And if you start playing with those, with these kind of more adaptive, you know, are you not introducing bias along the way? And that's going to get the question I had earlier about precision of your results. Are you
Right. So no is the answer. All of this, like none of it's free. When you look, you have type 1 error that you have to account for. So every look has to have type 1 error. So if they're type 1 error controlled, so we make sure we control it to like 2.5% on each side or something like that. So there's no change in that, for sure. If you hive off a population because you think it's performing differently, now you're going to have a power issue in that one population. So you're going to have to go longer. So like there's no like magic that occurs. So you have to have the money and the resources. But if it's an important question, then get the money and the resources. But because if it's someone like, you know, if it's like, I don't know, like lung cancer, and if it's this mutation versus that mutation is performing, don't you want to know that mutation? Because okay, let me go back to the heparin example. And I'm sorry, like that heparin example where critical care was harmed and moderately ill patients benefited. Imagine if we reported that as one trial. What would the point estimate be?
Mm-hmm.
0. It would have been an effect estimate of 0, an odds ratio of 1. How would that have helped you? It wouldn't have. That's the perfect example right there. And so it allowed us to then come up within the population of a group that actually benefited and it was actually harmed. Totally would have not been known if we ran it like a traditional trial.
Yeah, no, I think that speaks to the difference between accuracy and precision. You lose accuracy perhaps by, you know, having all these patients sort of lumped in there together and losing these sort of subtle individual effects. But in terms of the precision of the benefit for the patients who do benefit, I do wonder if maybe that's not as accurate as you would have had maybe with the more traditional random allocation methodology.
Well, and you can separate noise from signal too, man. If you have a lot of noise and a lot of groups that are benefiting and not, your dispersion's high, that is variability, you could be going for a long time. And hiving off a patient population with a consistent benefit allows you to be more precise sometimes. So your actual overall sample size may actually go down if it's, you know, if you're picking out a highly targetable patient group that you wouldn't have had otherwise, because they would have mixed in with noise. So don't assume that the how that precision and accuracy plays out does depend on what the trial is doing.
All right. Well, listen, we are a little bit over time. Such an interesting subject.
So thanks for welcoming it anyway. It can be new for some people. Yeah.
Yeah. I'm gonna have to think about when we set the curriculum for next year. We might want to even have 2 sessions on this because I think there's so much to be said about the operationalizing of this as well. But anyway, with that, I think we will sign off for this month's session. Thank you, everyone who tuned in.
Yeah, thanks for joining.
And we will see you again in a month. Okay. Bye, everyone.
Thanks a lot.